Okay, thank you very much, colleagues, for joining us again on a Tuesday for our clinical care webinars. I am Dr. Lese Homawela, and I'm just going to officially welcome you and really appreciate you for joining us this evening. Today, we are going to look at a broad topic which is going to focus on rehabilitation, mental health, and breast cancer. So I'm hoping that this will also be hugely a value-adding session to you, but importantly also to your loved ones and other people who are affected by breast cancer. I've just welcomed you, so feel free to engage with us. Just remember that you are allowed to use the chat for questions, and we also have a Q&A section on the Zoom section where you can post your questions, and we will continue to engage with you through those two particular channels. For those of you who are joining us for the first time, just to remind you that the clinical care platform has a mission to improve the way we care for patients through educational resources and evidence-based education. Our focus really is to enhance clinical practice and the competence of you, our health professionals. I do know that today we might have non-healthcare professionals who are attending because this is a very important topic and it affects many people out there. So you are also welcome to join us today. For today's webinar, the topic is rehabilitation and mental health impacts of a breast cancer diagnosis. So we want to understand the journey from a patient's perspective, because most of the time when we discuss amongst ourselves, we have the same view about medical conditions. So today we are going to look at breast cancer from a different view, and hopefully we learn a lot about how best to care for our people and our patients and help them and provide the necessary support. The rationale behind this webinar is that a cancer diagnosis and treatment are often traumatic events, and many women struggle to cope during this period. Rehabilitation care can repair and restore the physical and mental side effects after many of the treatments that we give to our patients leave them weak, fatigued, with psychological distress, and also in pain. This webinar will particularly explore the role of rehabilitation in supporting our clients to live life beyond breast cancer. Today, usually I would be saying our speaker she is our speaker, but more importantly, she's an ambassador for cancer, Miss Lindiwe Ntuli-Tloubatla. She's a cancer ambassador who was diagnosed with breast cancer in her early 40s. She will speak today about mental resilience, how to become strong, and how at the personal level she has dealt with challenges that arose during her diagnosis, treatment, and recovery from breast cancer. We have a panel today. You will see that it's not a very clinical panel. It's more around the support and the rehabilitation, that is required for our patients. We have Mr. Lutendo Phaswana, who is a physiotherapist, Dr. Kenneth Segwapa, who is a specialist plastic and reconstructive surgeon, Ms. Maria van der Merve. She was with us in the previous topic when we discussed pregnancies. She's a dietitian. And we have also Ms. Nomazinga Manzini, who is a psychologist. Last week, we discussed breast cancer, and some of the team members, especially the surgeons and the radiologists, Dr. Bitumelo Pakati, also Dr. Ignatius, and also Dr. Tabiso Malefatro. They'll be joining us as well. And I'm hoping that where there's still questions about clinical issues, they would really come handy to help us to deal with this topic. I am not alone, as usual. I'm with my colleague, Dr. Joshua Segule, who is a specialist ENT surgeon himself, someone who's really passionate about how we are responding to COVID, but he continues to be a convener and the director of these sessions. Dr. Segole, let me hand over to you. Take it from here. Thank you.
Thank you, Dr. Mawela, for such a warm welcome and introduction of our guest. Certainly, psychological distress and pain is what us as healthcare workers need to know how to deal with it, most likely from the patient-oriented terms, Good evening to all the attendees, panelists, and most importantly, our best guest speaker, Lindiwe Ntuli-Tloubatla, for making this time to share with us life stories and experiences that she has engaged through her journey as a survivor of the breast cancer. Today, our focus is mainly on survivors, patients that are still going through therapy or treatment, and the community-oriented, as opposed to our previous discussions where we had more of clinical talks rather than not focusing on the patient, as Dr. Mawela has said. This is just a follow-up to our previous formal discussions in the last week where we had general surgeons, plastic surgeons, discussion about how we diagnose it, oncologists and radiologists. Today we're going to have a personal or passionate experience from somebody who has suffered this dreadful disease, but has survived it, which we are so grateful for that. We also appreciate the initiative, as we spoke about the early detection. That is very important, and we spoke about our screening programs that we need to employ or rather deploy in the communities. Dr. Lungamini, we appreciate your initiative on your YouTube channel. Let's follow her, and then let's try to engage with her so that we can educate most of our community members. The proceedings will be, I'll have a discussion or a one-on-one sort of interview with Ntuli-Tloubatla, and then this will be followed up by the comments by the panelists, and then we'll have a Q&A section. Ntuli, are you ready for me?
Yes, I'm ready.
All right, good. Just quickly, ma'am, welcome. Thank you so much. I know we spoke a bit earlier, and like I've said, you've always looked beautiful, irrespective of what you've went through. And that's what we appreciate. And I think as young guys, we need to take this home. You always look beautiful and stunning. Thank you so much for gracing our clinical care platform and making time to be with us. You're welcome. Good evening.
Good evening, and it's a pleasure to be part of this august occasion where you reach out by providing information and support. Thank you.
You're welcome, Mama. Let's go straight into it. It's exactly 7 minutes just after 1800. We are live on the clinical care platform. Could you briefly just tell us who you are and where you come from, please?
Well, in short, my name is Lindiwe. My slave name is Octavia, but I was born Lindiwe Ntuli. My official surname is Ntuli-Tloubatla. Then Home Affairs made sure that I get the name Octavia. Then Lindiwe Ntuli-Tloubatla is a human rights activist, a gender catalyst. I'm a menstrual hygiene advocate. I'm an ambassador for cancer. And also at the same time, I'm a Cancer Association of South Africa volunteer and fundraiser. Ek was gebore en getuie by Middelburg, na die Witbank, and I was also raised between Middelburg and Witbank. Thank you.
All right, thank you. We welcome you all, and we are just so grateful that we realized that this cancer or breast cancer that you had survived did not deter you from your daily obligations or your duties, and you still continue to be our human rights activist and all other things that you have mentioned. When people talk about cancer, we always get scared. And as clinicians as well, we always get worried that could this patient be having cancer or not? And one of the other things that we've been always asking ourselves is, how do they feel it being diagnosed with cancer? So now I want to ask you, you having recovered from this, can you please tell us what made you to stand from your home to say, I'm going to consult and I'm suspecting that I could be having this and that? What happened so that you just went to consult?
Yeah, first and foremost, there's one sentence that no human being wants to hear, which is you have cancer. Because there is a lot of death associated with the disease itself, and it becomes scary when you get such news as a person. And also when you come from a family, your collective of family and your collective of friends, they do get traumatized on receiving the news that one of their own has cancer. So in my case, what was happening is I come from a family that has a history of cancer. At that time, my sister, Tandega, was busy with gallbladder cancer. And somewhere between that time, my cousin, my uncle's child, was dealing with leukemia, and I had an aunt that was dealing with. And as for me personally, September 2000, I was diagnosed with early stages of cervical cancer. And when the womb was being taken out at that time, it was later discovered that there was a spread to the ovary, which was removed at the time. So because of that experience, and at the same time, because of that in our family genes from the maternal side, there is a history of cancer. So all the about everything, our diet, our lifestyle and everything. So like we had a culture of saying every year we go for a mammogram. And also we do these self-examinations when you are in a bath or in your shower. Sometimes even you are alone in your room, seated watching TV, you just examine your breast. So in my case, I was doing one of those self-examinations in a shower. That's when I detected that there was a small lump. If I wasn't doing the examination, I wouldn't even have realized that lump. I was able to detect that there is a lump. Then that was alarming for me. Same time, I didn't even go straight to office. I went straight to the female wellness clinic where we did a mammogram. I got the results of the mammogram same day. As it was happening for the past 14, 15 years, the report from the mammogram cleared me. It said there's nothing. But still, I couldn't accept it because I knew I felt the lump. I went further and demanded further tests to be done. That's when an MRI was done. Then the results of the MRI, for lack of a better word, I would say they were inconclusive. There was no direct affirmation from vet confirming that there was actually cancer in my body. That's when I started doing my own personal research to say, if I suspect this, what more can be done? What are the processes that our scientists usually do? That's when I was able to discover that there is a more accurate test that can be done that will give an accurate report, which is evidence-based. That's when I went for a biopsy. I did a biopsy. I didn't get the results immediately. It took some weeks, I think, before I got the results. Then the results of the biopsy came back. It said you've got breast cancer in both breasts. And by that time, when the results arrived, there was also now discoloring in the breast. Actually, within a short space of 4 to 6 weeks, I moved from having a lump to something that felt like a huge stone on the breast on my right-hand side. Then the one on the left-hand side, it was bits and bits of lumps that I could pick. So they said you've got breast cancer, stage 3. And then they said locally advanced. And then they further said you are supposed to be operated, but unfortunately, based on the size of the lump or whatever that was in the breast, now you are inoperable. So I went to a psychologist. I mean, not a psychologist, I mean the oncologist, meaning I moved place that was supposed to assist me to a new oncologist, because what they told me in that place where they were giving me the results, They say, Sisi, we don't think you will make it beyond December 2019. Just take your investments, resign from work, take a vacation with your kids and your family, enjoy the last 3 months that you have. So at that time, I had to take a decision. Do I want to fight this? Yes, I was ready for the fight. But do you want to fight with them? Then the answer said no. I cannot have a team of soldiers that has already given up on me. That's when I took a decision of saying, let me research around nail spray. I learned about the oncologist Netling. I also learned about another oncologist, Dr. Sarita Retief. Then I consulted with her. She interpreted the results more or less the same, but her attitude was different because I could feel that this person was to join the fight and fight with me, meaning the positive attitude and her demeanor in handling the whole thing was very good for me. Then she recommended that I see a surgeon. I went to Dr. Barnett. Unfortunately, I cannot operate. You are 100% inoperable. You have to go back to the oncologist, try chemotherapy treatment, and let's pray that chemotherapy will shrink the whole thing. Then once it gets shrunk, then we can try and operate. So I hope that.
Yes, certainly, Mami, quite an interesting story. And, you've already covered almost 30% of my follow-up questions to our discussion. But interestingly so, some of the things that you have highlighted or you've touched on is things that we have discussed previously on our clinical care platform. Just as a follow-up question, in terms of you feeling the lump self-examination, I commend it because it's one of the things that we struggle so much in South Africa since we don't have the South African guidelines in terms of early screening in breast cancer. Rather, we use the American guidelines. So I will encourage that we improve in teaching our young girls or even old women to learn how to self-examine. The history of positive family history, I think that's one thing that we always take for granted, either as a healthcare worker or non-healthcare workers. That's something that we really need to look into, that we encourage people that have got positive family history of certain disease. They must consider being checked up regularly so that it can be picked up early. As you know, that early detection saves a lot of lives. That's the first follow-up question, Mami. You said you felt a lump in one breast, and surprisingly, it was both of them. Were there any other symptoms like pain or discharge apart from the lump and discoloration that were coming from your breast?
Yeah, in my case, there was no any excretion that was coming out of the breast. And on the initial consultation where I was doing the biopsies and the mammogram, there was no pain at all. If I was an ignorant person, I would have actually ignored all the signs. But as the time transgressed, while I was waiting for the biopsy results, I started feeling extreme pain. I think within a period of 4 weeks while waiting, I ended up using Schedule 6 medication. That's how painful it was.
All right, thank you. Yet again, one of the other things that we touched on was the issue of availability of the results and the time for the return of the biopsy results. Dr. Brenda, the pathologist, I don't know if she's in the meeting, you can see it was not a thumbs up thing. We were talking about the harsh realities about our healthcare system that often than not, our patients, we have to wait for long to get these histology results, which could actually make a huge difference if we could get them earlier than we expect. Umama had to go through the pain of waiting for the results. And I also can imagine, rather than the physical pain, the psychological impact and the psychological pain that she suffered, awaiting the unknown results only to be told about cancer. So, Ma'am, when you received these results of the biopsy and you've been told that you've got cancer, what went through your mind, psychologically or physically? What transpired?
I've missed the question. Can you repeat it? You were hanging and cutting at the same time.
All right, my apologies.
Dr.
I'm saying,
Dr. Segole, maybe we can switch off your video and leave Mama's video just for data, and then we see if maybe the communication is better. Thanks. Yeah.
All right, no problem. Can you hear me now, Mama?
Yes, I can hear you.
Oh, yes, good. I'm saying I can imagine you waiting for about 4 to 6 weeks for the histology results, and then you want to even extend of suffering a physical pain with the use of Schedule 6 drugs, you know, while waiting for the histology result. It could have not only been a psychological, physical pain, but also, I'm assuming that psychologically there could have been some distress and you wondering, you know, what will the results be, you know? And then my question to you is the waiting and as well as getting the results, what went through your mind being told that you've got cancer after surviving the cervical cancer?
Honestly, the results was just a verification and a confirmation of everything. Because at that time, I already knew that the report that is coming back won't be favorable because I was already seeing the changes, even the discoloring of the breast. And I know all the symptoms that are associated with breast cancer, the signs and all those things. But also psychologically, I can't say I suffered much. Maybe it's because of the type of a person that I am and the type of a character and the personality that I have. I always call myself that I'm more than a conqueror, and I'm a very strong person, and resilience is my middle name. I've been through certain challenges in my life, like when you read my book, because I wrote a book that is called Mercy Rewrote My Life. It's also available on Amazon. You learn a lot about me and where I come from as a person. So I never gave myself the opportunity to suffer psychologically, because in every situation that I come across in life, I always tell myself that the body, the mind, and the soul have to work as a collective in fighting this with all that I come across in life. And then the other thing, I always say I need to be mentally, emotionally, and psychologically strong for me to win whatever challenge that life throws at me. So that also helps me a lot. And then the other thing is that we always live a life where you say, I'm happy, I'm comfortable. We wish things could be like that all the time. But life is life. It has its own challenges. So every time a challenge comes across, I always tell myself, you know what? This is not as comfortable as it used to be before. This is a new reality. This is a new challenge. Then with that in mind, to make sure that there are no negative challenges, there's no negative impact that can be brought by stress or by any punitive experience that I'm facing at the time. So with everything that I come across in life, I always use the mind to fight whatever that I'm facing at that particular moment. And then the other decision that I took also on receiving the news, I said, you know what, I'm not a pity party person. I'm not going to sit around the table, cry, and do 1, 2, 3. I need to fight this. I need to prepare. I just said, when soldiers go to a battle, they prepare in advance for that battle. They prepare even before the commander-in-chief can give the date for an attack. So I said, you know what, you need to start preparing for this while you wait for the results. So in the meantime, trying to succumb also the physical pain that I was going through, I engaged in intensive research. I said, fine, what treatment options are there? I use a prior knowledge, the knowledge I gathered while I was supporting my sister or any other family members that has gone through the experience of cancer. With that knowledge, with that information, I also did my own research, understanding deeply what is chemotherapy, understanding what is radiation, what is chemo radiation. I also gathered information of the treatment options that are available in South Africa in general, and treatment options that are available within the Lowveld region, in particular to the oncologists that I will be working with. And I also did a lot of research on the oncologists that I will be working with. So within that period also, there's a lot that I was doing, and that also assisted. And I also learned a lot about alternative medicine that is available out there as far as cancer is concerned. That's when I started learning about Dr. Sebi. What was his thinking? What was his understanding of cancer? Why he was killed? Did he have any children? Yes. What are the children doing at the moment? What is available from Dr. Sebi? That's when I started learning a lot about the Kalauga herbs and all the other herbs that did more extensive research on cancer to say, despite Dr. Sebi, what is underlying and which is supposed to be out there, but down there as far as cancer is concerned, and why we are not finding a cure for so many decades for this particular disease. So I started understanding the socio-economic challenges within the cancer world, both from a global perspective and also from a local SADC related perspective. And during that research that I was doing at that particular moment, I started learning also more about what Brazil is doing about cancer, what London is doing about cancer, what is that hospital in Israel, the Sheba Medical Center in Israel, what is it that they are doing. So having that time, it gave me a lot of time to do a lot of research. I was able to know about Dr. Pezhensky, the work of Dr. Pezhensky, the work of the Pezhensky Foundation in the US, and also the outlets that are out there as far as the Pezhensky Foundation. And I was also able to tap into the herbs that the Pezhensky Foundation are doing, the Rovo, the Real Build, the Power Pereira. And I did a lot of work. I'm one person who believes in lifelong learning. I'm one person who believes in research. So I did a lot. Hence I say, I didn't want to do a pity party. I didn't want to sit and cry, because, you know, when they tell you that you've got aggressive cancer, and secondly, you will need aggressive treatment and all those things, it forces you to go deeper into research. It forces you to be more aggressive in your approach. The history that I have and the background that I have as a person and as a social being teaches me that if you are faced with an aggressive situation, at times you need to be equally aggressive to diffuse or to win that battle. When a person comes with an AK-47, we present the AK-47, then we'll see what happens in the end. Thank you.
Thank you so much, Mami. Quite interesting and quite alarming. We thank God that you've got such a strong personality and a psychological comeback to this kind of treatable disease. It's not so many of us, or not so many of women out there that will have such kind of strong personality. We commend all the women that are like you, and then we commend you to work on them so that they can be stronger than you. Here you still you are alive. You've been told that you are left with 3 months, and then you are still alive. You know, Dr. Segwapa, this questions our scientific approach to these things, and Dr. Buitumelo, the way we speak to our patients as well can have a psychological impact, you know. And I can only imagine if somebody does not have the strong personality as you have, the strong psychological knowledge as you have, the abilities to do the research and all those, what will happen to those kind of people, you know? But lucky enough, on our panelists, we also have a psychologist who later will tell us if in such cases where we have people that will really seek psychological support, that do not have that kind of a strong personality like you, what will they normally do? Manzini is here in our platform, will tell us more about that later. Mami, so you were told this is stage 4, it cannot be operated. So you were not operated at all.
Yeah, what happened is eventually I went through an aggressive chemotherapy, which was very traumatic, by the way. And to God be the glory, because the outcome of the 6 cycles that I took at that particular time were able to shrink it. Then when I went back for consultation with the surgeon, I remember I came in the morning, then the surgeon said, the window is open, we have to operate, and we have to operate within the next 48 hours because we as we all know that cancer is a rapid replication of the cells. So the surgeon was afraid that if we prolong the window period, you might end up losing it. I remember I consulted in the morning at 2:00. I had to go for a 12-hour surgery. They did what we call a bilateral mastectomy, meaning both breasts were removed, and I was left with 2 sexy holes, which I still have. I look at those scars even today. I don't look them as scars, I look them as victory. Other people, when they look at them, like when you're with a family, you are free, you get naked and do whatever. Someone might look at me and say she is incomplete, she is imperfect, but I always say I'm perfect with my imperfections. I'm complete with whatever the next person sees as incomplete, because this is me. This scars symbolizes the battle that I've gone through as a woman. They symbolizes the strength in me. They symbolize the strength of the superpower that I believe in, which is Yahweh, which is Jehovah Jireh, Jehovah Rapha, Emmanuel, Elohim. So I always tell myself my life is a testimony, because it proves that I'm a spiritual being that lives in a spiritual world. So the superpower that operates in me can even defy science. I'm not undermining science. I'm an evidence-based person, and I respect science a lot, but I just had to say it, Uti, the greater that is in me made me to overcome this situation. Hence, I'm still here and standing today. I'm not saying the battle is over. I'm not saying there are no challenges, but I'm saying once you win your battles mentally, and you approach it in a way that says the body, the mind, and the soul, they work as a team, they work as a collective, you can win every battle. The minute you lose your battle in your mind, your soul and your body responds to that. So let's win all the battles mentally as a starting.
Thank you so much. Just as a sideway question, do you know what is the meaning of Octavia?
I don't know. It means 4 or 8, something like that. It has to do with a number. 8 or 4.
Nomazinga says to you that Octavia is a definition of resilience, and she is a fighter of resilience.
Yes. Oh, thank you very much.
Resilience.
Yeah, resilience, yes. Mommy, I know you are left with the scars, and simply because of your psychological well-being and being a strong woman as you are, it's good, you can overcome that. But I can imagine the young generation that could not live without their physique, what will happen in those kind of situations. But lucky enough, in the panel, we also have Dr. Kenneth Segwapa, who's a plastic and reconstructive surgeon, and I know she's a field of interest. It's breast reconstruction, and she has done even some celebrities, So she'll take us through. If you still want your breast back, what can she do? What can he do rather to reconstruct your breast? So don't feel deterred. And even the young guys in the platform, or those that are suffering from this dreadful disease that may have to go through surgery, there are people out there, scientists, that can do a very good job. But I'm glad that you have learned to live with those scars and you appreciate them. And it's a token of you reminding yourself that I've went through an ordeal and I've survived it. Just the last 2 questions in closing before I go to my panelist, Ntuli-Tloubatla. Overall, as a woman, what would be your advice in general, including everyone not diagnosed with breast cancer, to say we need to look out for this kind of diseases as early as we can, so that they can be survivors like you, just as an advice to the women and men who get breast cancer in the audience?
I think as a starting point, we need to deal with the fiction that is out there, like saying cancer is a white man's disease, because we still have people like that in the community. And they forget that this is one disease that cuts across all races. And also there is a strong myth out there that says breast cancer is only for women. We need to go out there and advocate and share the information widely that even men do suffer from breast cancer. And then the other thing that we need to do is teaching our communities on what to eat, when to eat, and how to eat it. Because people eat so much unhealthy and they lack the knowledge and understanding that we are what we eat as far as our health is concerned. And also we have communities that are more focused on social media, more focused on television and other stuff. They forget that the body needs some exercise. As much as the stomach needs some food, the body needs to exercise. So we need to encourage our communities about the importance of exercises and how their health as a whole can benefit from exercising. And people have a mentality that exercising means going to Virgin Active to do that. Walking, just setting a target for yourselves that every day at least I do 11,000 steps. This is something when you wake up, your body, drink a lot of water. Healthy living is what we need to be preaching, and it's what we need to be sharing on our social media platforms, and deal with this obesity and unhealthy living and eating that is taking out there, because those are the triggers, factors also towards some of these diseases, towards cancer itself.
Thank you so much, Mami. Lucky enough, we've got a dietitian, Umaria van der Merve, with us, who's our friend in the clinical care platform. She'll probably give us a 1 minute or 2 minute comment on that later during the discussion. And we also had a physiotherapist who will tell us more about these exercises that you're talking about. People could be listening, suffering from breast cancer or suspecting that they've got breast cancer, but the mom who's talking about exercises, they're wondering which exercises are these. Just a last question before I release you, and then after the last question, please stay with us on the platform. There's quite a lot of comments that I need to read it out for you, and there'll be a lot of questions for you as well. In closing, with the journey that you have went through, you have given an advice to the general public. Us as healthcare workers, with the journey that you went through, being told that you'll die in 2 weeks, you know, having to wait for 4 to 6 weeks for results for biopsy and all those kind of other challenges that we went through, no psychological support. What will be your advice to us as healthcare workers in the panel so that we can improve on our services? Just in 30 seconds, Mami, before we go to other speakers.
Yeah, the advice I can give you to health professionals is that the person that you see in front of you is a patient. Always remember, Guti, this is a human being. This is a mother to somebody, a sister, a wife, a colleague to somebody. So handle with care, because as a cancer volunteer and ambassador, I'm nursing and supporting a lot of people who would say, I have been manhandled at that level where I thought I need to be protected. I'm not blaming anybody, but I'm saying that patient in front of you is a human being with patients' rights, with humans' rights, and with a family behind that person. Take care.
Thank you so much. Colleagues, audience, panelists, you've heard it. You need to see people as human beings, mothers, sisters. And we've got a survivor of breast cancer, Nomazinga Ntuli, an ambassador of cancer awareness. What more can we ask for? You've heard it yourself. If you've got any questions or any comments, please on your chat box or on our Q&A section, please feel free. Dr. Mawela, before I go to comments, Dr. Kenneth, be ready, please.
Guys, I am Dr. Lulu. I am a registrar in radiation oncology. I have a special interest in breast cancer. And most importantly, I like teaching patients about breast cancer and all sorts of other cancers. And I've got a YouTube channel that I've started up, and it's basically about teaching people, in layman's term. This is now not for medical students, it's not for interns, it's for our patients. I'm all about early detection. I'm all about teaching people what to look out for. Guys, my YouTube channel is Tackling Cancer with Dr. Lulu. Please subscribe, please share. We can teach as many people as we can. Remember, if we can save one life, we would have done the best. So guys, please do share, subscribe, refer patients, most importantly, so that people can be educated. Okay, thank you guys. Looking forward to interacting with some of you and your patients. Thank you, bye.
Thank you so much. Yes, early detection, this is what we talk about. And lucky enough, Ntuli was able to do self-examination, positive family history, and this was managed to be detected. As to whether it was early or not, it's another story to be discussed at some point, but it was picked up, she survived it, she's still going strong, and we appreciate her presence and sharing a story, very inspirational, very inspirational. Dr. Segwapa, Ntuli-Tloubatla had bilateral mastectomy. I can imagine if it's a young girl, who still need to have that physique, cosmesis. We talked about it last week, that it's not just an organ, it's also an organ for hormonal reproduction, sexual arousal, the looks, and all those kind of things. From your point of view, what would be your comment and what is your take on these kind of issues that we deal with breast cancer? Thank you, Dr. Segwapa.
Good evening, everyone, and thank you, Dr. Sekole and Dr. Mawela, for inviting me to this clinical platform. After listening to Mam Lindiwe, all I could say is, wow, what a phenomenal woman. Her tenacity, her resilience is unmatched. Actually, she reminds she reminds me of me, because in 2018, I was diagnosed with prostate cancer. I had to undergo radical robotic prostatectomy, but I didn't let that get me down. So I'm just like her. Me and her, like they say in the streets, are in the same WhatsApp group. Miss Ntuli, thank you very much for your tenacity, your resilience, and your continued work in this area. What is it that is available from the plastic surgery point of view? Basically, this is Breast Awareness Month, which means breast cancer is not only dealt with by one discipline. It's a multidisciplinary sort of approach. And I'm happy today, all the other allies and other supportive disciplines have been brought in to support the people who are living with breast cancer over the years and those who survive it. Breast cancer affects about worldwide 1.4 million women and is the most common cancer. So as plastic surgeons who would like to be involved, when the surgeons start diagnosing at that moment, they should consult us so that we go together as a team and advise patients on and give them options on what is available. In my practice, I've seen patients like Mam Lindiwe who come with scars, patients who should have come to us before they've even been operated. Some patients have got operable tumors that are small and they have mastectomies. And if we were approached earlier, we would have done something called oncoplastic surgery, where we use breast reduction techniques to preserve the breast but take out the tumor. So what is available to you, Mam Ntuli, now that you are left with scars? Now, there are a few things that we can do as plastic surgeons, but what I would like to say is surgery is usually the mainstay treatment for breast cancer. But sometimes, like in your case, it was inoperable, but you got neoadjuvant chemotherapy that shrinked your cancer to an operable situation. Hopefully they even sampled your axillary lymph nodes. And normally during those first consultations, that's why we want to come in and advise on the complications that will arise, like lymphedema, where your arm on the sides that you both bilateral, you might have that problem. If they sampled the axilla, you might develop bilateral lymphedema, and there is help from plastic surgery. There's newer techniques that we use that improve patients with lymphedema. So again, what is available, because this breast cancer, we can use what we call breast conserving surgery, or we can do mastectomy, because this has got a serious physical impact after mastectomy. You know, the diagnosis only of a cancer has severe psychological impacts. And also the fear that you will use a femininity that really puts patients down. That is why most of these patients, why do they choose breast reconstruction? Is because it will eliminate the use of prosthesis. You know, sometimes we can do the reconstruction immediately. So the ladies, they don't feel that they had lost a breast. So if we do it late, sometimes they've got that depression that, look, I'm living with one breast and I don't have another breast. And of course, you don't get limitation to clothing when you've got a breast reconstruction. And of course, you regain your sense of wholeness. But some people are against or do not want to have a breast reconstruction. Why? Because they have fear of the complications from the surgeries we do. They also feel sometimes they are too old for the operation, or they feel if I do a reconstruction, it might mask the cancer that is in there, and that might prevent surveillance and treatment. So from the plastic surgery of you, Ma'am Ntuli, and the audience, the options that we have to reconstruct, really, it can be done immediately, depending on the biology of the tumor and whether the patient is going to have radio or chemotherapy, or we can do it late after chemo and radiotherapy are completed. Options available to us immediately, oncoplastic, like I said, but we can use your own tissues, which we call autologous breast reconstruction. For example, you know, women, I'm a plastic surgeon, so I do a lot of tummy tucks. So which means women come to me, we take the lower part of the abdomen and throw it away. But in breast cancer patients, that we can use to make a new breast mound with. So with microvascular surgery these days and perforators, we can actually take any part of the body and make a new breast with. The other option, basically, is we use implants. You know, what we do is after radiation, the skin has shrunk, and we know that the vessels are not good, because when we take tissue from one place to another, we take it with these vessels under the microscope, look for other vessels and combine them so that it can have blood supply. So what we do, we put what we call an expander. We remove the scar, put an expander to increase the volume of the skin envelope. And then after that, we remove it. We put an implant, like when women with small breasts wants to enlarge their breasts, we put implants. So we put an implant there. But because the skin that was in front was not good, from radiation, we then take a muzzle from behind and cover the implant with that. So those are the options that are available, which are called alloplastic, which is material that is not yours, and synthetic things, and autogenous. Yeah, with those few words, I think, you know, when listening to Ma'am Ntuli, I really commend you, Ma'am Ntuli, for what you went through and the resilience that you have. Keep it up and don't give up. Thank you.
But again, you look too fresh to have suffered a prostate cancer, but thank you, you encourage me.
I'm just like Ma'am Ntuli, that is called, I'm resilient.
Yeah. That's what we need to hear. Thank you so much for your comments and the questions that you have made available to us and the breast cancer sufferers or survivors that are out there. They'll certainly come to you at your Acacia clinic for consultation. Thank you so much. Please stay on the panel for the further few questions that will come out later from the audience. Before I take our physiotherapist, Lutendo, can I just, Dr. Malefato, are you with us? She's a general surgeon. She's a friend to us in the clinical care platform. Gave us a few comments last week. Just a quick one, not too long, straightforward. Umam Ntuli said she had a lump and discoloration. She did not have a pain discharge, but then diagnosed with stage 4 cancer.
Yes. Thank you very much, Doc. This brings us back to that point we were discussing last week about misstaging the lump clinically. Just because of the size, you tend to think that it's a lower T stage. But you have to look at things like muscle infiltration as well as skin involvement onto that lump, which is what actually takes the T staging much higher. So, and the higher the T staging, the most likely it is that it has gone to the lymph nodes and other places. So when you're examining the lump, yes, we look at the size and we look at it in relation to the size of the breast also, but most importantly is the relationship of the lump to the skin and to the muscle underneath.
Oh, okay. All right. Thank you so much for clarifying that. Quite important. I still say early detection, but thank you so much. So the most important is the relationship of the lump to the skin. Thank you, Dr. Malfatro. You also stay with my panelists. It's Mr. Lutendo Phaswana, our physiotherapist in the panel, Dr. Mawela. Lutendo, Umam Lindiwe talked about exercises either before or after or during breast cancer. We always wonder, what are these exercises? Have you got something for us, Lutendo? Mr. Phaswana?
Right. Thanks, Dr. Sikuna, and thanks, Dr. Mawela, for inviting me, and thanks to Dr. Segwapa for the indication of what gets to be done, what are available options right there at the quicker way of doing things. But obviously, the question maybe should follow more informed by what Dr. Ngwenya was talking about last week here, the aspect of quality of life. Why comprehensive rehabilitation? Why bring almost everyone in the table probably before anything gets done, so that we can give the options to the patients and say, we are going to do this. This is what would happen, but this is how you can counteract some of these things. Because as we talk about some of the activities or surgical procedures that gets to be done, a tummy tuck and mastectomy completely, there would be issues of complications that will come out of these procedures that gets to be done. Unfortunately, I mean, I still need to say, Ma'am Ntuli is amazing. When you think of what she has gone through, I thought when Dr. Sekula was asking her, what are the other challenges, she would then indicate, hey, maybe my shoulder, cannot function as well as it was supposed to be, and all those other challenges that comes with some of these procedures, the very lymph problems that gets to be there, pose some of these procedures. And that being the case, you would then want to have a joint, focus in optimizing the outcome, more especially regards the functional status and the quality of life. Dr. Ngwenya indicated what's the use of all these processes if at the end of the day the patient may not be happy, or we may never have actually addressed or tried to address what other issues they are having. We are talking about mostly women. There will be confidence issues. For sure, the psychologist will talk to that. There would be generally how they are looking. They become an important aspect of what the outcomes would be. How they are able to perform some of the activities of daily living would be even as much important, whether they will be able to cook quite easily by themselves, or will they need somebody else that will then have to assist them because now the shoulder is frozen, or they are unable, they are having back problems because of a tummy tuck that was done, or tummy tuck that was done to try and create a new breast by the plastic surgeon. Eventually, over a long period, they are probably experiencing a back problem. So this joint focuses on, addressing the pre-existing or treatment-related comorbidities more than anything else. Treat chronic effects of the treatment, because whether it's radiation or the surgical procedure itself, afterwards they would have the side effects or the undesired effects of what the treatment was trying to achieve, except that the endurance aspect that comes with these very processes, that you will find that the immune system is a little bit, affected at the time, the HB level at the time, probably they are such patients that are affected to that extent that they are unable, or they wouldn't know when else to start performing certain exercises, because they will develop dizziness, they will feel weak and feel like maybe my best option is to sit and not do anything. But that being the case, we would want more than anything else. The prevention aspect is that we need to promote self-management, something that I actually heard succinctly here when Mam Ntuli was talking about it. She's one of the few and the advocate and ambassador of note we are learning here, because she's able to go through all these other processes by herself. But what about other patients? What about other people that may not have as much resilience and as much knowledge on what to go or on how to go about it? So at this particular point, we need to promote self-management and healthy behavior that will prevent further problems, and that decreases the risk of recurrence and the risk of death that she was talking about, that many people will then have fear of due to the comorbidities that will follow. As soon as we start failing to move, one thing that we need to appreciate is that everything revolves around movement within life. And as soon as we start stopping, or we stop doing the daily activities that involves movement, the comorbidities or some comorbidities develop. And in that situation, whether it's hypertension or whether it's you're just becoming obese and unable to do certain things, eventually you'll be stuck, and your body is going to have to function or try and function at a little bit higher intensity to maintain the little basic of homeostasis that we need to be able to run a day-to-day activities of our life, generated or starting from the cells themselves. So that becomes the bigger approach and focus in what we're trying to do. The next aspect is, to coordinate the sum total of the problems and the needs that may be given by the patient, because if we then have this joint aspect, we are able to sit and say, okay, this is what is needed, this is what is needed. And from all different aspects, we are able to say, this is what I'm going to do to counter this. We know this may be a problem, but we'll address it with this. And eventually, we are then able to come up with a better outcome for the patient with more confidence in whatever that he or she may have been struggling with. One important aspect is to prevent the spiral into disability. If she was doing some work, she's an ambassador now, we need to preserve that aspect, that she can still be able to go back and be an ambassador and be able to teach other people. And if we don't do that as a role of rehabilitation, yes, the surgeons will do whatever that they are supposed to do, but we need to also look ahead and focus at what else was this person doing? How do we then restore the dignity of being able to go back to do what they were doing and they were proud of? Probably that's what gave them purpose of life along the way. And if you remove it and never focus on it, they may as well feel like maybe my life should have ended at this particular point. So those are some of the things that we then give credence to. Amongst other things is to add you are then having a continuous surveillance. With rehabilitation, there's continuous surveillance that you are able to, to bring into place, where one of the treating clinicians was not available or is not able to see the patient as regular, but some team members are able to be in contact with the patient as regularly as possible. And that becomes an important aspect. So my presentation here, the main objective obviously is to also develop the best practice of cancer rehabilitation service and promote safe and effective rehabilitation during all stages of cancer rehabilitation. And one thing that we need to remember is that much as we get the increase in the research and the knowledge that our surgeons are coming with and the oncologists that are coming with, we then have a dramatic increase in the survivors, especially at the older age or the adult age. But there's multiple comorbidities that accompanies this particular aspect. The chronic effects of treatment because of the age also becomes an important aspect. The need, obviously, to prevent this becomes an important model in the survivorship care, which at this particular point, when you look at Mam Ntuli, having had the cancer before, survive, and I'm calling it survivorship care because then something happens again and she picks it up again. And somebody was supposed to be there to carry her along the process so that it doesn't become as difficult to access some of the services that are there at this particular point. So what kind of exercises, as Dr. Skula has asked, I think it's all dependent on impairment based at that particular point. You would find that patients are a little bit totally different in their presentation. But one thing that we do know is that most of them post some of these procedures. They will present with pain, they will present with anxiety, and they will present with a number of things that you now feel that they need to be addressed on time before, fatigue generally and lack of sleep. At that particular point, you want to create more aerobic exercises outside the idea.
Mr.
Yes.
Unfortunately, I'm going to interrupt you. Your time is up.
Yes.
We still have
Okay.
5 more speakers. My apologies, my brother. Just wrap it up quickly.
Okay.
We appreciate what you're saying. It's very important. But time, we still have 5 more speakers. Thank you.
Okay. Well, I was saying the exercises that we would look into would be more of aerobic exercises to try and improve endurance, to try and improve the intake of oxygen when they are exercising, to encounter the very idea of fatigue. And that in itself will go on and address the idea of insomnia, because it is a way of releasing endorphins, which will then be able to, be a little bit more relaxed and are able to sleep and counter the idea of fatigue. And the pain will be an aspect that, as I indicated, impairment based, we try and address the challenges that are there, different movements that are there, and every patient would have patient-specific exercises that are dealing maybe with the shoulders or the shoulder and the back, if they had done a tummy tuck to try and get to create the breast for the patient. And maybe just a quick wrap up to say, what happens if survivors who have impairments don't get rehabilitated? Obviously, you would then have more economic burden to some of these guys because they have to go back and see the relevant specialist as many times. And if they were to do it early, it will reduce the early retirement, because if they don't, they then have to go and be boarded and not do anything anymore. And just poor health as they go forward, and quality of life becomes so affected that they would have to keep seeking for assistance from the healthcare professionals. Thank you.
All right. Thank you so much, Mr. Phaswana. We thank you, appreciate. I think the take-home message that we had from you is that we need to improve on pain, endurance, and fatigue. And there are a lot of options and exercises that you guys can offer, either pre-op, intra-op, or post-op, because most of the time it seems like they suffer from shoulder pain, from target arm and back pain. It may be metastasis at some point, and we really appreciate that. I'm sorry I had to cut you short because we still have other speakers, and then we have a Q&A section for about 20 minutes. Maria van der Merwe, the dietitian. Ma'am Ntuli spoke about diet that you need to follow. Is there any specifics that one need to follow, especially if they've got breast cancer? Briefly, in just less than 60 seconds, please.
Thank you very much for the opportunity. I'm keeping my video off because of my signal not being very stable. I would like to just mention, first of all, in terms of preventing cancer, there are specific dietary factors that we know contribute to the risk of breast cancer. We know it's primarily genetic, but there are specific things in our diet and lifestyle that we know can add to that, and we can elaborate on that if there's time later on. The second part would be, if you do have the diagnosis of cancer, what to look at in terms of a balanced diet. We aim to attain and maintain an optimal weight, and we also look at consumption of a balanced diet and varied. So a variety of foods with a great focus on vegetables, fruits, whole grains, your legumes and pulses as primary sources, with a limited intake of sugar, limited intake of saturated fats, focus on your beneficial fats like your poly and monounsaturated fats. And then, quite interesting that I had to remind myself, alcohol consumption is also very directly linked as a risk factor, any alcohol consumption, with pre and post-menopausal cancer. Very briefly, also to consider, while the patient is receiving cancer treatment, we very often need to intervene in terms of dietary adaptation because of the symptoms the patient may experience, ranging from poor appetite to change in taste, sores in the mouth, dry mouth, etc. So it's very important, while your patient is receiving treatment, that we make sure that they are able to consume the right food to still maintain the nutritional requirements. And then, very lastly, I'm aware of time, just to also reflect on Mom Ntuli's really wonderful, I think, life journey and testimony, where she had a positive outlook and support, etc. But that's not always the case. And just a reminder to us as clinicians to keep that in mind, that the support system and structures back at home may differ for our families, and sometimes they are the pillar and they don't want to show their pain and their emotional struggle to others. So just how we can always also consider every patient's circumstances, because as clinicians we tend to look at the clinical side and to be reminded that there's more to that. There may be parents at home or children at home, and the patient may suppress their emotions for that reason. And one very quick thing I want to mention, and then I'm closing off and we can take questions for more details, would be, for example, if the patient is going through a difficult time, how can they make contact with us? Who are the people that they can contact with if they need additional support beyond the direct medical care that we provide? I think I'm just going to stop with that overview, and then if there are any particular details for more discussion, I'm happy to take questions.
Thank you so much, Maria, for always being able to afford us your time to this platform and your valuable inputs. If there's anything that the audience or the panelists will ask you in the Q&A section. But what I figured out from you is that diet can also be a risk factor apart from genetics. Quite interesting. We appreciate your support and we appreciate your comments. Before I take our psychologist, Nomazinga, Dr. Brenda, can you hear us, our pathologist in the platform?
Hi, Dr. Skole. I can hear you. I just joined you guys, so I missed the gist of the discussion. But yeah, I can hear from the testimony that you had a brilliant speaker today.
Yes, you'll get the recording. Quite interesting. One of the other things that she said, Dr. Brenda, is our pathologist in the platform. One thing she said, which got me worried and raised my eyebrows, was that she had to wait for at least a long time to get the pathology result. And during that time, what was physical pain even developed into a psychological stress and distress, and the physical pain was unbearable, and then she had to take Schedule 6 drugs. Now, from the pathologist's point of view, what are the measures or things that we can do so that we can fast track the result in terms of histopathological diagnosis?
Thank you very much, Skole, for having me again today. I think the issue of histopathology results has been a big problem, especially in the public sector. I think we all know about this. And this is mainly due to the shortage of histopathologists in the country. But I always say that when we have urgent biopsies like that, when we clinically can see that the lesion already shows attachment to the skin, there is ulceration, and we know that this might be possibly malignancy. It is worth following up with the histopathologist. Our contacts are always available. I'm no longer in public sector, but I'm always available to actually, contact the guys that are there to actually fast track the results to make sure that we get reporting quickly. But one other thing that I'm going to reiterate again today, Skole, is the availability of, fine needle aspirations. To say that if we can go out there and train, our colleagues and even our healthcare workers, our nurses, to perform proper fine needle aspirations, this could give us, a quick turnaround time. I just had a patient today in my clinic, and I did one. And what I do usually in the clinic is that you get results before you leave the clinic. And this is done in other provinces like Western Cape as well, where within the surgical OPD in the clinic, they have a trained nurse who can actually do fine needle aspirations. And we also train them to interpret them so they can basically pick up a malignancy. And at least those patients don't get to go home without being booked in the SOPD clinic. So I still think that training, like you said, and outreach is very important for us to minimize the turnaround time.
Thank you, Doc. Sekole, are you there?
Thank you so much, Brenda. I just wanted you to repeat, especially the part of the FNA, especially for those who were not in this platform last week and the non-healthcare workers, that there's such facilities where the turnaround time can be improved. And I think another thing that you have mentioned, which I think is very important, is communication among us as doctors or surgeons or pathologists, oncologists, especially when you clearly have a high index of suspicion, to say, look at this specimen with agency. I think it's very important. Thank you so much. Manzini, are you there? I cannot or overemphasize the issue of psychological well-being when you have been diagnosed with any form of cancer, regardless. Ntuli, lucky enough, she has a strong personality, and she could overcome all these psychological aspects of psychological distress. I'm just going to point of view. What can you offer?
Good evening again.
Good evening.
Yes, good evening. Thank you so much. Maybe a few things that I can mention that some of the patients will experience once they are diagnosed or when they are going through treatment. I also want us to be aware that it not only affects the patient that is being treated or receiving treatment, but also the family gets affected as well. It also affects, the partner that is with the patient. What is mostly common, obviously, with the severe psychological distress, one may present with depression and anxiety. People tend to feel as if they are a burden. That is when they will start withdrawing. There will be changes in terms of communication. There will also be sexual problems. People will tend to experience separation, or they will even terminate relationships, because of the state that they're in. And again, it's because of the anxiety and the fear that they are experiencing. We should also be aware that they will also tend to develop, self-blame. They will tend to ask themselves a lot of questions. Why is this happening to me? What is important is to try and assist them in terms of, a positive cognitive restructuring, help them to rephrase certain things, help them to, have a new relationship with their body, and also to try and eliminate any false self-perception, to encourage them to, to socialize and to interact, and to also improve communication, especially with their family members and friends, and to also try and lessen the burden that they tend to experience, that they are sick, they are not able to take care of themselves, and they see themselves as a burden. But what is also most important is for us to learn to encourage them in terms of having a new relationship with their body, especially if there are going to be major changes in the body because of the treatment that they are receiving, be it chemotherapy or radiation. I think that is very important. And also how they can rebuild their lives and rebuild their image once they slowly start becoming better. And I think that is very important. We also need to ensure that we invite the family as well when we are treating our patients, whether it's to provide them with psychoeducation, but also to form a very good support system, which is needed, not just only with family, but if there isn't any, close family member, if there is a friend or there is another form of family that is around, be it church or being it, a colleague from work, as long as they form a part of the supportive structure, that is quite important. But as I said, I want to emphasize this again, the positive cognitive restructuring is actually very helpful for anyone who is going through any type of diagnosis that seems to be impeding on their mental health.
Right, thank you so much. You've got it. You've had the options, and yeah, this is what our social support structures can offer to us, and quite important. I can imagine if you're going mental distress or psychological distress, it's not something that anyone can see. Most of the time as clinicians, we tend to attend to things that we see, a lump, a growth, or an ulcer. That's when we start to be proactive. But if somebody has got a psychosocial or mental distress, it's not often that it gets to be picked up. And yes, Ma'am Ntuli, we do have support, and on top of your personal support that you had, or your personal confidence and everything, you still have an extra support with you. And colleagues, Ma'am Ntuli is not just only an ambassador, like she has said. She wrote a book as well, just to take her through a journey of life. For those that would like to have it, it's available on Amazon. It's called Mercy Rewrote My Life. I'll just give a bit of a 1 minute to 2 minute comment. Why the book, Ma'am Ntuli?
Actually, what was happening after going through the journey and the experience that I went through, I thought it was worth it to share the information and also to prepare other people that might be faced with a situation which there's at least more information out there. And also the book's intention was also to teach people that as much as this is a scientific battle, science and spirituality connect and they help each other. If you combine them as part of your healing, it will really, really assist. And most importantly, the other thing that I remember that motivated me, I come from a family that is blessed with very long hair, but because of chemotherapy, I lost my hair. I changed completely. Even the skin tone that you see now, I used to be 3 tones lighter than what you see now. So there were a lot of body changes. So the book also aims to teach women out there, women in particular, and people in general, to say, love yourself no matter what. you can win this, you can beat this, don't give up, don't give in. Basically, in a snapshot.
Thank you so much. Very powerful for sure. We'll go and rush to the shelves on Amazon and order it online. We really appreciate.
Yeah, those that are in Nelspruit, I do have hard copies. What is key about the hard copies, there are also images at the back. They show me going through chemotherapy, surgery, and all those things. So the pictures are so graphic to an extent, Yoguti, they could not be included under Amazon. Those that are in Nelspruit, they can get it. The copy is 250. You get it from myself or the publisher. And then on Amazon, it's $9 or $11.
Oh, okay.
Thank you.
Thank you. We'll certainly support you. Dr. Mawela, while we take the Q&A section, maybe you can leave the slides of that book. You know, I see few hands. I don't know if they are really true hands or false hands. Today, surprisingly, we don't have much of the questions. The questions that we had have already been answered, and then some of them have already been answered in the previous platform. Like, can we quickly check those hands are true hands or not, Dr. Mawela?
Dr. Sekole, if possible, may we take the Bushoma, what's her name? Sipati. Yes, if she wants to say something, she had.
Four hands. Can you just check if those other hands are true hands? There's Motseo, there is Larik, there's Kabamba, there is Luisa Mbokazi. If your hands are up by mistake, please take them down. If they are true hands, leave them hanging there. And if there are any other hands, please raise your hands as we start with Boshoma.
Sipati Bushoma, you may unmute your mic, ma'am. Sipati, are you there? All right, I think.
The other hand, please. We'll get back to her. There is Koza and Larik. Michael Larik. Oh, Boshoman is there, yes. Sipati?
Good evening, how are you?
Good evening, please shoot.
Hello.
Yes, Dr. Sekole, Sipati made a comment that she's also a survivor of breast cancer. I'm not sure if she wants to make a comment or she wants to ask a question. Thanks.
No, not really a question. I'm Sipati Bushumane. I was diagnosed with breast cancer in 1995. Did mastectomy early 1996 and radium therapy. Fortunately, I did not go through the chemotherapy, but I did the radium therapy on the medial sternum below the two breasts. And I'm still attending yearly treatment just to check if there are any cancer cells. And I'm happy to say I'm a survivor. I'm okay. Thank you.
Thank you so much, These are untold stories that we want to hear in this kind of a platform because they really motivate us, not only as clinical associates or healthcare professionals, but also as other attendees that are non-clinical. It's encouraging and it will give a positive message out there to say we can really beat these things if we are really motivated and seek help. And we say congratulations on you again for beating it and continue talking and motivating others as you can. We thank you so much for taking also the courage to speak to us on this platform. We appreciate. There is Michael Larik. Mukadi Kambamba. Please unmute your mic if the hand is a true hand. And Louisa Mbogazi.
Oh, hi, Dr. Sekole. I just wanted to reiterate what Mama Lindiwe has been saying. Unfortunately, our patients are getting younger and younger. So breast cancer patients are becoming, relatively younger and younger. And we definitely need the positive messages of survival. Unfortunately, all we ever hear about cancer is death. People get the one message that is being sent through is that when you've got cancer, you're definitely going to die. And unfortunately, that affects the psyche. And remember, with treatment, patients who actually do well are patients who are mentally and, they are spiritually inclined. Those are the patients that actually do well. So the positive messages of survival are very, very important, and we barely get those. So I think I'm just here to just tell the survivors that we appreciate you guys and thank you so much, and please continue to spread the word. Thank you so much.
Oh, thank you. You've logged on with a different phone or a laptop. It's Dr. Ludlamini, the video that we played actually before and during the panel interview. She's got a YouTube channel that she's on about early detection. And we really appreciate your initiative, because one of the other things that we spoke about quite frankly, it's about early detection. And I think your initiative, it's one of the powerful initiatives, especially living in the era of social media where information is easily accessible. We appreciate. Thank you for your inputs, Doctor. Kapamba Mukadi. It's Kapamba Mukadi. Yeah? Dr. Mawela, I don't see any.
Yes, I can hear you.
Yes, please. Your comments or questions?
Okay. Yeah, no, thank you for the presentation. I've been so impressed. Even our patient that got healed, we were so impressed with the presentation. What I want just to give as an input here, diagnosis of cancer, it's always a stressful situation for any patient. Immediately cancer is diagnosed, patient will just see death, majority. So the effect of always remind to the general population that whenever any abnormal lesion is discovered, when patients consult on time, there is always a chance of survival, a chance of healing. Otherwise, those who are presenting late give us a kind of a challenge in terms of managing this cancer. When they are at an advanced stage, it becomes a real issue. But out of that, I think we are satisfied with the presentation, and thank you very much.
Thank you, Mukadi Kabamba. Let's go out there and spread the message so that we can improve on this early detection, like you are stressing. And it's through this kind of clinical care platforms where we can actually improve in these awarenesses. Let's go there and spread the message.
Exactly.
Dr. Malefetro, you have got a comment? Tabiso? Dr. Malefetro?
Sorry, thank you very much, Doc. Sorry, my mic was not unmuted. I wasn't aware. Thank you. I wanted to make a quick comment before we move to the Q&A section, please. I'm really glad, I must say that we have a platform like this where we can involve the plastic surgeons and the allied health to join in, because truthfully speaking, in the past, when we spoke about breast cancer, they were not really much involved in the talk about breast cancer, and there's so much more that gets affected with regards to breast cancer than just removing the cancer itself. Another allied health that I feel that should be included in the future is orthotics, because they play a very important role when it comes to temporarily how the patients look before they can get their reconstructions, or when they are unable to receive the reconstructions, and that can improve the psyche of the patient a great lot. So orthotics, they make devices that patients can use, and certain bras that patients can use, that when they are dressed, then they don't look like they have one breast. So maybe in future, if we can involve those as well to come and speak. But I'm really glad that we involved allied health. Another thing that I wanted to comment on is with Mama Ntuli's speech, she talked about how she went to neoadjuvant therapy. with the because the cancer was inoperable. And I must say, we do see those a lot. We do get a lot of neoadjuvant therapies in our patients because they present late. It's still a struggle in our country. But another challenge we're facing with that is that if the chemotherapy is so good that the lumps actually disappear, now we have a problem convincing the patients to actually come for the operation, because now they start believing that they are cured, which is another message we need to get across. So when you've been sent for a neoadjuvant therapy or chemotherapy or oncological treatment before the surgery, because your cancer was considered inoperable prior, it doesn't mean that if the lumps have completely disappeared or the ulcers have closed or the skin changes have disappeared or the nipple is no longer retracted, that you are cured now. Because if you don't go ahead and do that surgery, like Mama Ntuli explained that the surgeon wanted to do the surgery within 48 hours because they were afraid that it can come back. If you don't do that surgery after that neoadjuvant therapy, you will definitely have a recurrence which can be much, much more worse than the initial one. We see it a lot. Our patients, they disappear and they don't follow up. Because now they believe they are cured because the chemotherapy took the lump away. 6 months later, they come back with metastatic disease. So just to make note on that one. And another interesting thing she mentioned is that she had cervical cancer before the breast cancer. She can please correct me if I didn't hear correctly. She did say, right, she had cervical cancer before,
yeah.
And
Yes.
then she was later on diagnosed with breast cancer, which is actually very interesting. That one person went through both those cancers, which comes back to that point we were discussing last week when we were talking about other cancers that could be associated with breast cancer. Now we know that cervical cancer is not directly associated with breast cancer because it's not directly associated with the BRCA gene. However, you get other syndromes that can predispose the patient to both breast cancer and cervical cancer, which I'm not saying it's Mom Ntuli had that syndrome, but it's something we have to have at the back of our minds. Patients with Lynch syndrome, Lynch 2 syndrome especially, they can be predisposed to breast cancer, and as well as they are at 6 times more risk of getting cervical cancer than any other one. So we have 2 types of Lynch syndromes, Lynch 1 and Lynch 2. With Lynch 1 is usually the colorectal malignancies, and that they get cancers at very early ages and they are hereditary and non-polypotic. But with the Lynch 2, it's other cancers in the bodies that get associated, and breast cancer and cervical cancer are also on that list. So it's just something to have in the back of our minds as clinicians when we take history from patients, that we're not necessarily just asking for history of breast cancer per se, but history of any type of cancer that they know in the family, because they might not just have a BRCA gene mutation, but there could be certain syndromes that run in the family as well. Thank you for the time, Doctor.
Thank you so much. We always value your comments, quite valuable and educative. And I did not know about this syndrome. I don't want to lie, but thank you so much. We can always improve, and your inputs are very important, especially in what you have said, education, and especially to those patients that go to radiotherapy or chemotherapy and the breast shrunk and they still need salvage surgery. It's very important to educate them. And then the involvement of other supporting structures, which are called orthotics and all others. I did not know about that. And it's through this platform, like I've said, that we learn about those things, and very important and informative. Thank you, Dr. Malefatlo. Just before, Ntuli, are you still there with us in the panel?
Yes, I'm still here.
Do you have any questions to my panel, the surgeons or the audience or the support structure or the host, not me?
No, I don't have any questions. I was just enjoying the inputs that were being made. You know, they say information is power. I've gained a lot today and appreciate the platform and the work that is being done.
All right. No, thank you. We thank you so much. Before I hand over back to Dr. Mawela, let me take this opportunity again. It's exactly 19:35. We went over with at least 5 minutes. Thank you so much, all the attendees. Thank you, my panelists. Thank you, those who have commented. Thank you, Dr. Louis, for your YouTube channel. And most of all, thank you so much, Ntuli, for gracing this occasion and also honoring the invite. And also thank you, our C party, for taking the time and also to have the guts to make such comments on this clinical care platform. Often than not, if people have got cancer of any sorts, they tend to shy away and they want to hide it. We are proud of you guys. We love you so much. Please live longer for us. Dr. Segwapa, thank you. Live longer for me. I need you, my brother. I'm glad you have survived this prostate cancer. And to everyone, thank you so much for attending. Dr. Mawela, thank you so much for the platform again, and back to you.
Yes, Dr. Sekula, thank you very much for your willingness and for always really steering the ship. To Mam Ntuli, you know, when I called you the first call, I was not sure whether you were going to be, you know, interested and willing to participate. But having listened to you today, now I know that you are always going to say, you know, yes, because this is what you have been called to do, to empower, to encourage, and to inspire. So we are really grateful to have you on board today. To our panelists, I know we didn't give you enough time, especially to talk about your roles and when exactly do we get you involved in the process, because it seems like half the time you get called as an afterthought when things have already gone wrong. And we need to come back and really discuss this interdisciplinary approach to how we care for patients and ensuring that every team member brings, you know, their expertise, their views, and their skills in the care of our patients. So we really appreciate your time. I see Dr. Malefatlo, Dr. Brenda, you came back again this week to say we are still here. We really appreciate. We know it takes a lot of your time and we appreciate it. Colleagues, let's support Ntuli. You know, she's got a book. I know a sister of mine who was diagnosed a few weeks ago. Last week, she was told that she needs to go for chemo and radiation. I'm going to get a book, this book for her, because the other weakness in the whole process is counseling and support. I was shocked when I spoke to her that she has never been to any psychologist, not any counseling session. She was diagnosed, she was a lumpectomy with the lymph node dissection, no counseling. Now she's going to start chemo and radiation, still no counseling and support. I don't think this is the best way to manage and care for our patients. So we need to come back and really give this topic enough time. Please contact Lindiwe Ntuli-Tloubatla on this number there, 080-998 or 9988-750, and really order a book, this book for someone. It might not be someone who's living with cancer, but I think someone who needs to be inspired, who needs to be motivated. We are all going through some level of psychological distress. Just in closing, to update you on one key thing is that we are working on a number of training programs. So please be on the lookout. If you are planning to write any of the college diplomas, we are working on preparatory courses and a number of short courses. So until you hear from us, may you enjoy your evening, and we hope to see you again next week, Tuesday. Thank you.
Thank you, Dr. Mawela. Good evening.
Yes.
Guys, I am Dr. Lulu. I am a registrar in radiation oncology. I have a special interest in breast cancer. And most importantly, I like teaching people, I like teaching patients about breast cancer and all sorts of other cancers. And I've got a YouTube channel that I've started up, and it's basically about teaching people, in layman's term. This is now not for medical students, it's not for interns, it's for our patients. I'm all about early detection. I'm all about teaching people what to look out for. Guys, my YouTube channel is Tackling Cancer with Dr. Lulu. Please subscribe, please share. We can teach as many people as we can. Remember, if we can save one life, we would have done the best. So guys, please do share, subscribe, refer patients, most importantly, so that people can be educated. Okay, thank you guys. Looking forward to interacting with some of you and your patients. Thank you, bye.